Hi, everybody. Welcome back to another episode of Hybrid Healing Hour. Today, I have a very special guest on who is near and dear to my heart, Kathleen Simervil, and we are going to be discussing addiction medicine. So, Kathleen, I would love for you to introduce yourself and tell our audience a little bit about you, including how you know me.
Sure. Thank you, Deanna. My name is Kathleen Simervil. Like she said, I'm a physician assistant. I had the pleasure of working with Deanna back in the day, I think it was 2020 era, before that, 2019.
So
we worked together. She actually hired me as my first PA job outside of school, so that was a very fun and exciting time in my life for sure.
Remind me, where did you go for your training?
I went to Kaiser University down in South Florida, or South Fort Lauderdale.
And you were doing your last rotation with me.
I was. I finished out my last rotation with you, which worked out perfectly. Yeah. Started right away. Started working with you right beside you. And it's been great. So that's where my PA career started. And here we are, full circle.
And
right back.
We were working at that time together in it was technically family medicine, but we primarily worked with people in recovery, in addiction medicine.
Right.
And so you learned the ropes right from the beginning, and I'm assuming you found it interesting enough to stay in that field.
Shockingly, I did, yeah. I had no intention when I was in PA school to go into addiction medicine, to psychiatric medicine, anything like that, but I really wanted to get my feet wet in family medicine, just kind of learn everything as much as I could. That was a great opportunity, and then I just kind of fell into addiction. I mean, I really loved seeing the end result of somebody come to sobriety, come to recovery, come to a whole new life for themselves. So ever since then, I've been all in on psych. I've been all in on addiction. It's been a great, really fulfilling field.
Well, and tell me, you went on and got further training.
Right.
Because I know with addiction medicine, the way things used to be is we needed an waiver license, right, in order to be able to write opioid-like medications like Suboxone to help with what we're going to dive into, like medicated or medication-assisted treatment. But you went on, because things have changed, and I also want you to talk about that. But what is the training you further pursued?
So I have my CAQ. It's a certification of added qualifications. It's essentially an additional board certification in addition to your general physician assistant licensure. You have to have 2,000 hours working in the field. So my field obviously is psychiatry. You also have to have about 75 CME level 1 credits to go ahead and apply for the test. And then once you get approved to take the exam, you take the exam. They offer it twice a year. You take that, and then if you pass, you become CAQ certified.
I'm sure you passed with flying colors.
I did.
I mean, you only learn from the best, right?
Right, exactly.
So let's just dive right in. So I want to talk about what's the difference between, I guess, addiction, substance abuse, and misuse.
Sure.
I think that's hard to tell the difference in a clinical setting sometimes, and it depends on what the patient all tells you.
Absolutely. So yeah, that's a great question because it is hard to differentiate between the two. So misuse can be anybody taking an additional pill than they were prescribed. That could be it. They do it one time, and that's technically misuse. Addiction is really where things kind of get chaotic. They are misusing medication. They have issues in their lifestyle that's becoming an issue because of the use, and they continue to use. It can also be related to, say, a patient, started taking a medication. Now they've developed withdrawal symptoms, or now they've become dependent on this medication. If they don't have it, they're going to be sick. So there's a lot of different factors that come into play, but that's the main two that, between misuse and addiction, there's a big difference.
I'm assuming the main types of medications associated with these are opioid medications, or do you also see it with like stimulants like Adderall and Vyvanse and et cetera?
That's a great question. Yeah, you'll definitely see it with both. So any of the controlled substances, obviously have the potential for misuse, which can lead to addiction, which can lead to dependence, which can lead to building the tolerance. It's just kind of a slippery slope from there. But we see it both. I mean, it really just depends.
I mean, I think people don't realize that medications are not benign, right? So even like gabapentin, that's something we prescribe for like nerve pain. And it is not a controlled substance here in the state of Florida, but it is a controlled substance in almost nearly every other state.
Right.
It's very similar to another medication called pregabalin or Lyrica, and that is a controlled substance. So it's quite interesting how they're very, very similar, but yet one's controlled, one's not.
That's a great point.
Yeah, and I think people don't realize like, oh, I'm feeling the pain, I'm going to just take another one, or let me take a higher dose than what my doctor prescribed, and it doesn't mean it's okay.
Right.
And like another medication that, you know, like tramadol, right? That one's not necessarily like a C2. There's different levels of controlled medications, right? Controlled substances. C2s are potentially like stronger, more. I mean, they're classified that way for stronger risk of abuse, right? Or misuse.
Exactly.
And so tramadol is not as considered a C2. I think it's like a 4 or 5, something like that. But people think it is just another benign medication, but it's actually an opiate derivative.
It's absolutely not benign, and especially gabapentin. That's a great point. A lot of other states do have it as a controlled substance. Hopefully Florida will follow suit. I mean, I think it definitely has the potential. I've seen it in my practice where patients definitely will misuse and abuse their gabapentin. So, and like you said, just very similar to Lyrica. Very similar medications, and for whatever reason, the Lyrica is controlled in Florida, but the gabapentin's not. But we always have to be vigilant, and we have to be very careful when we're prescribing these type of medications.
Right. And kind of, I'm going to offshoot a little bit here. Recently, I just read something about kratom. They're thinking about knocking down this to be an illegal substance because currently it is not. And you can get that in gas stations.
Right.
And at tea shops, like kava shops. You can get it very easily. And I remember when we were working together, I mean, this is years ago.
Yeah.
People were telling me they were addicted to kratom, and they ended up misusing it first. They were taking a little more. They developed a tolerance to it, so then they needed a stronger dose or more of it.
Right.
And eventually they're coming in and they're saying, I'm sweating. I'm having withdrawals from this. I need to get off of it. And you know, I would help them with that. So, I mean, on the news, they reported that kratom is like 13 times stronger than morphine, and yet you can get this at a gas station. So do you see this in your practice?
Absolutely. So kratom is absolutely a huge issue. It's extremely accessible. You could go buy it with a Gatorade, with a pack of chips. You know what I mean? You go into a gas station, it's right there. I don't even know if you need to show ID.
Right.
It's scary. So yeah, there's definitely a dependence issue with it. You easily will build a dependence towards it where if you don't take it, you're going to be sick. You're going to be sweating. You're going to go through those acute withdrawal symptoms like you would with a full opioid agonist. So kratom, there was actually recently a new supplement, quote unquote, that they had on the market called 7-OH. It was a kratom like alkaline or alkaloid that they put on the market. They said it was a little bit stronger than actual just taking kratom. It was something that they were able to extract from the kratom and put into capsule form. I think it also came in gummy form. And that was really wreaking havoc. And I really saw that in my patient population. Just recently, though, they actually took it off the shelves and they made it a Scheduled I narcotic. So just like cocaine, just like heroin, fentanyl, whatever. They're like, we're not selling this anymore. And I had a lot of patients come to me and they're like, I am withdrawing. I don't know where to find my next dose, basically. And they were really struggling. So they kind of, reached out for help, and it's been a huge issue.
So what I'm hearing is some of this is unintentional, right, and some of it can be intentional for like addiction. Can you maybe talk about how, addiction and the understanding of whether this is actually like a brain disease or versus like a moral failing?
Yeah, of course. So yeah, we've come to learn this is kind of relatively new data. It's always been stigmatized that it's, a moral failing and you're just a bad person because you do drugs, but that's not the case. We've learned that this is a chemical dependence towards substances, and it's happening, and your reward system gets rewired, and there's definitely a medical component where it needs to be treated as a medical condition because that's what it is. But to kind of go back to the kratom, I mean, the way that it's advertised, it's so... You can innocently be like, oh, this looks like something that can make me feel good without any issue.
I think I literally saw advertisements. It says relax, free.
Right.
I think they call it free, or freedom
right.
is one of the brands.
Right.
Yeah, I
think feel free is a big one.
Feel free. Yeah, that's what yeah, exactly. And to me, that's just astonishing. When I see feel free, I'm going to be like, oh, what's in this? Let me take,
Right next to the green tea.
Exactly.
You don't know. Yeah.
It's amazing. And so, I mean, luckily we have the knowledge to read ingredients and see what are in things, but so many people don't understand what they wouldn't even know even if it said 100% kratom. There are people out there, they don't know about this.
This could be 100% innocent.
They're going to say, this is a plant, right? It's a plant-based. There's no way this could be bad for me.
The way that it's marketed is scary. It really is.
I mean, I'm
truly.
seeing, like, I worry about children out there.
Exactly.
You know, like, this is, yeah, I can't wait for them to crack down on this. And, you know, speaking of that, like, what would be some early signs that healthcare providers out there or loved ones should look at for probably misuse or addiction starting in their family or friend?
That is a really good question. So yeah, what you could notice is some behavioral changes. Maybe someone's being a little bit more sneaky than usual. Some things maybe just aren't adding up, or you notice, hey, they're taking more medication than they were prescribed, or they're running out of their medication earlier, or you see like drastic shifts in their mood. Maybe they're really happy one moment and the next they're freaking out, or you even notice physical symptoms. Maybe they're sweating, maybe they're irritated or agitated, you know?
Or fidgety.
Right.
Yep.
Fidgety, restless, all of those things.
I also find isolating, right?
Yeah.
So, like, if they all of a sudden don't want to go meet you on Friday night, or they're going to stay home, or they constantly coming up with excuses not to meet up.
That's a great point.
Yeah.
Definitely.
Wow. And could you go ahead and touch on, like, do genetics play a role in this? Or is this just, is there anything that is particularly an increased risk of developing addiction?
Yeah. So studies definitely show that there's definitely a genetic component. I would say about 50%. So if you have a family member that struggles with addiction, you probably have about a 50% chance of developing some sort of substance use issue yourself. So ways that you can kind of work around that is obviously be vigilant. Don't put yourself in risky situations. Like, make sure that you are keeping track of what you're doing and making sure that you're not doing anything that is on a slippery slope that can lead you to a path that you really don't want to be down.
So I feel like that goes right hand in hand with mental illness as well.
Right.
And I think there's definitely an overlap as what we call in the industry a dual diagnosis,
Right.
Of having some form of mental illness and addiction, right? And the one I see most is, like attention deficit disorder. You have impulsive behaviors and you're at an increased risk of being impulsive with saying, oh, let me try it. Let me do, whatever. And then there's other ones where you're depressed or having, bipolar, like ups and downs, and you're going to self-medicate. So is there anything you can add to that? Do you see one worth, with the other more than?
Oh, absolutely. So yeah, ADHD is a big one, bipolar disorder, anxiety even, because what we're doing with substance use is we're looking for a way out. We're looking for a way not to feel these uncomfortable sort of emotions that come with disorders like that. Or, I mean, honestly, it could be something like, let me just try this to see if I can focus a little bit better. So yeah, definitely ties in hand. There's an increased risk if you have any sort of those psychiatric disorders or any sort of diagnoses like that you're at an increased risk for substance use. So another time to be vigilant, to be aware of what you're doing in your surroundings and, how you're doing things.
I think it's really important to also have cognitive behavioral sessions with a psychiatrist or with somebody like yourself.
Totally agree.
I think, I will say, like, according to the DSM criteria, I personally have ADHD, and I've never
Can confirm.
and I've never taken medication for it. To be honest, I have tried prescribed. Okay,
Right.
Didn't like it. Didn't work for me. Not in my field where I'm multitasking all the time. If I had
Right.
to just sit and study, maybe, right? But to be able to multitask, it just wasn't for me. And I went to therapy. I learned ways to reel it in.
Right.
And so I try to teach my own patients things like that, because I feel personally that something like that is where you can work to overcome it. And if I see I'm in an impulsive behavior right now, I need to stop, count to 10, breathe,
Yep.
and reel it in. And it's more about awareness, and it's more like, and that's where I will rave about behavioral health techniques.
Totally agree with that. So yeah, CBT, DBT, all of those sort of therapy.
What's the DBT?
That's the dialectal behavioral therapy. So still behavioral therapy, but it's going to be a little bit different. So that'll be geared more towards like borderline personality type, things like that.
Okay.
A lot of inner work needs to be done where you need to kind of get educated on why you feel the ways that you feel.
Right.
And how to work through those sort of feelings. But yeah, when it comes to substance use, absolutely. They have to go hand in hand. Like, you can do as much as you can from a medication perspective. You can add in medication-assisted treatment. But you need that backhand where you're having the therapy and you're having that dual diagnosis, everything's treated.
Yeah.
Very rarely do I see a patient that comes in with no history of anxiety, no history of depression, no history of anything, and substance use.
Right.
Very rarely.
Right.
So they definitely go hand in hand.
What do you think about PTSD and the interaction with substance abuse?
Yeah, that's a great question. So you'll definitely see a lot of trauma when it comes to substance use. Again, substances are used as a coping skill. If you've never learned how to deal with maybe past traumas that you've been through in your life, then you will reach for something where you're not going to feel those hard emotions.
Right. And I know the trauma can be reignited easily and triggered by, day, night, it doesn't matter when.
Right.
Right. And depending on the patient's situation. But nowadays with medical marijuana, PTSD or medical marijuana is used to treat PTSD often and to help with sleep and night terrors, things like that. Are you seeing any dependence on marijuana?
I have seen it before, especially with the adolescents. They maybe started smoking weed and then they kind of grew to where they had to smoke weed to either eat lunch or dinner. Like they just had no appetite if they weren't smoking weed. Mm-hmm. Cannabis is one of those things that I have my opinions on. I definitely don't think that if you have a predisposition to, say, bipolar, schizophrenia, any of those mood disorders, that you should be partaking in any of that, because it can exacerbate the symptoms. It can also bring on any sort of mania. It can bring on a psychotic episode. So you have to be super careful when using those sort of products, especially now in this day and age. I know medical marijuana is very prevalent, and it's also a lot stronger than it has been in the past. So there's really intense strains, and people can really get messed up from that. It's not just like a very simple substance.
Right. It's not as simple, I think, as people think it was.
Right.
Or is, right?
They think it's a plant. They think it comes from a plant, comes from the earth. What can go wrong?
Right. And it's natural, but you're right. I believe it is much stronger nowadays than what it had been in the past. They're doing so much research on it now. There's different strains. They can blend different strains, right?
There's a time and a place for it. I'm not completely against it, but for my high psych patients, I tend to advise them to avoid.
Now, I also learned recently from another podcast, very reputable, that there's actually an interaction with marijuana and people on stimulants like Adderall and adolescents, we should say, I guess, and young adults.
Interesting.
That it can actually cause an acute psychosis. And people don't realize that. So I thought that was very interesting because I've actually witnessed that.
Wow.
And I did not know it could have been associated with that. So I thought that was very interesting.
Especially going back to the strains of cannabis. I mean, there are some that are more stimulating. So maybe the stimulants plus that, not a good combination.
Exactly.
Yeah.
So I would love for you to kind of let us know, is there any specific time in a person's life where they might be more vulnerable to addiction, like whether adolescence, midlife, retirement? What do you see in your...
Anytime there's a major change or a major shift in your life, so say you go off to college for the first time, your risk is going to be a little bit higher than if you were just hanging out at home and finishing high school. You're in your routine. That's a major shift in your life. Marriage can also be a major shift. So that's going to be, life-changing for a lot of people too. You now are living with a person. You now are responsible for another person's emotions. That can be a lot. That can be heavy for some people. Another example would be any death in the family, death of a close family or a friend or family member. Also, there's another one that I had in my mind. I just lost it. Having a kid.
Yeah.
Having a kid. That is a huge life change. That can bring in a lot of stress. Mm-hmm. And that can be have someone searching for a coping mechanism.
Absolutely.
And sometimes that comes in substances, unfortunately.
Well, and one thing that I have noticed, and since I've gotten out of the addiction community per se, where you're working with many treatment centers, and now I'm just in my, internal medicine practice, addiction does not discriminate.
At all.
I see it I've known this before, but I have several patients of high affluency.
Right.
And it doesn't matter whether you're rich, you're poor, college educated, not educated, race doesn't matter. It is everywhere. And that is why I really wanted to do this podcast with you, because I just wanted to bring awareness to everybody.
Absolutely.
And one of the things that I think I see a lot here in South Florida, where there's a lot of retirees, it's 5 o'clock somewhere, right? Like, it's just that mentality. Like, you can go, a lot of people go to the Keys, and you can start drinking at 10 a.m. It doesn't matter. We have bars open all the time, and so it's funny that I feel this area seems to be like an addiction capital of the United States.
Could not agree more with that. It's a lifestyle thing down here, and it's unfortunate. It's not a healthy lifestyle.
Right. And yet we have tons of people coming down here for treatment.
Right.
And then they're going to stay in this community, and it might be a little hard.
Yeah, that's true. It could be hard for them, but luckily, I would think in the sober community, they are really tight knit. So they have each other to kind of fall back on. And having a community like that is so, so important
You're right.
because it's easy to kind of fall to the wayside and go back to old habits.
Well, and that's why they have meetings. There's groups. Right. We have like, oh, let's actually talk about that. So why don't you tell us, let's start with the steps of, okay, so let's say one, how do you diagnose addiction? And then let's go through a typical process of somebody who may be struggling with addiction from the time they're diagnosed to the time of sobriety. Okay. Can you do that for us?
Yeah, absolutely. So diagnosis comes with the DSM-5 criteria. That's kind of like our guideline. That's our book. That's our holy grail, essentially. So that's going to have a series of symptoms that we can kind of go through. I think there's like 11 for substance use specifically, but it's going to be like, okay, misuse. Is this patient no longer doing their like responsibilities? Are they showing up to work? Is it affecting their day-to-day living? Are you taking a medication and you've built up a tolerance where you're needing more than you previously needed to take and it's not having the same effect? Are you having withdrawal symptoms? So those are some examples of the DSM-5 criteria that we can use to diagnose these patients. And then from there, we can kind of decide, okay, where are we in our substance use? Do we need detox? Is this something that I need to refer you to a higher level of care to go ahead and get a safe detox from? Again, this comes back to needing therapy. I think that's so, so important. You need to have both treated. Even if you don't have anxiety or depression, I think therapy is still very important in substance use.
And let's be real, you're going to have anxiety, depression at some point during your recovery.
Right.
Because you're changing everything you've been doing.
Exactly. We call it adjustment disorder. Yes. That's how we utilize it. So if you don't have anxiety and depression, you're probably going to have symptoms of anxiety and depression going through that. Totally agree. So yeah, so we'll start there and we will get you to the appropriate level of care, whatever that looks like, depending on what you're using. There's so many variables. And then, yeah, from there you kind of go to either treatment or we are able to treat it on the outpatient. It really just depends.
It depends on the severity, right? So let's say somebody's been drinking alcohol, right? Let's just use alcohol for an example. Okay. We can kind of briefly go through a little bit of each substance in a sense, right? So if it really is a solo substance, right. Most people are using several, right?
Exactly.
But let's just say alcohol only, right? So somebody is drinking heavily for 6 months straight every day. At least 2 bottles of wine. That's what they say. Right. So that means it's probably a little more than that. Okay.
Generally speaking, yes.
From my knowledge, they're going to be at risk for having complications such as seizures, and that would make them more to the point where it's dangerous if they were to stop abruptly.
Delirium tremens, the hallucinations, risk of death, honestly.
Exactly.
It's extremely
Seizures alone are terrible.
Right.
That can you die from that, right? So they need to go into an inpatient detox, most likely.
Most likely 6 months straight, absolutely. That would be my recommendation every day of the week.
Right.
No question.
And so if they were to go into a detox, there's different detoxes, different detox programs where it could be a 7-day, a 14-day, right? It depends on how well they do as well. Like every individual is different.
Exactly.
And then from a detox, it's recommended to go into what? PHP?
Yeah, so
or residential.
From detox, that's when you are fresh off of whatever you were using. You have 24-hour nursing care. You're in there. You're getting treated. You're kind of just going through it. A lot of patients just kind of sleep through detox. Mm-hmm. It's not necessarily an enjoyable time, but it's somewhere that you can go safe. Excuse me. And you can just kind of ride out any withdrawal that you're experiencing. They're going to try to make that experience as comfortable as possible. So you'll get some comfort medications. You'll probably be put on like a benzodiazepine taper if you're drinking alcohol. That's going to limit your risk of any side effects, including seizure. And then from there, you go into what's called residential, and that can be anywhere from 2 weeks to a month, just kind of depending. Like you said, everybody's an individual, everybody's different. Just depends.
Does residential include therapy as well?
It does. So yeah, you'll be going to group therapy while you're in residential. You typically will have an individual therapist as well. And then from there, you'll go down to what's called PHP, so partial hospitalization program. So that's going to be a little bit more freedom. You're still in group 6 days a week. You also will be meeting with your individual therapist at least weekly. And then from there, you go into what's called intensive outpatient. So that's, you go to group 5 days a week or 3 days a week, depending on where you are on the program.
And the group sessions for that would be only like for a half day, not a full day?
Typically.
Right.
Yeah, it depends on the program, but typically for an IOP patient, you'll go like 3 half days out of the week, 5 half days out of the week. And you can typically at this point start working. And then you're usually expected to start contributing a little bit to rent. So you've made it a little bit further in your treatment process. Maybe you got a couple months under your belt at this point. And then from there you go to OP, and that is usually optional. You're usually living in like a halfway house sort of situation at this point. You're no longer in the treatment centers, community housing that they call it. And you're working full time typically. You maybe go for like an afternoon group a week. You maybe meet with your individual therapist once a month. By that time, you've integrated back into society. And typically, in an ideal world, have a good handle on this substance use.
And hopefully you're attending then AA.
Right.
That's Alcohol Anonymous. And then, but regardless of the substance, like that was just an example I wanted to give for alcohol, but they have it for opioid addiction, for cocaine addiction. I mean, you name it. There's substance abuse. That is just a general trend of what would be recommended depending on the severity of that person's use.
Exactly.
Okay.
Yep.
Thank you for clearing that up.
Of course, yeah.
And I mean, there's facilities that this can be covered by insurance, right?
Thankfully, yes.
Okay.
A lot of insurances are moving towards being in network with these facilities, which has made it a lot easier to access treatment.
Good.
Yeah.
Yeah. And this is actually where we can kind of mention how we used to, the changes, right? So when we were working together, we had to have an X waiver certification to be able to write certain medications to help with people in addiction. Nowadays, because of addiction being so prevalent in the opioid crisis we're experiencing, they've kind of removed that or changed it, right? Can you explain?
Yeah, absolutely. So I want to say sometime during COVID, maybe 2021, they got rid of the need for an X waiver for your DEA.
Because I think there was a spike in addiction during 2020.
There
right?
absolutely
during the whole
was.
COVID.
Absolutely was. And there was such a need for opioid treatment. It's an epidemic for sure. A lot of people overdosing, a lot of people dying, unfortunately. It still is horrific. And it's still something that we fight for freedom from that every day. So yeah, they got rid of when you had an X waiver, you also were capped at a certain amount of patients that you could see monthly for this type of medication. So they got rid of that, and then they said, you know what, you don't even need an X waiver, you just need your DEA license, as you would to prescribe any controlled substance. So that really opened it up. So as a primary care physician at this point, you can prescribe Suboxone, you can help someone in that situation. So it really just made the access to that sort of treatment a lot more vast, which is great. Exactly.
I mean, they just want people to be able to get help wherever they go, right? Now, it is up to that primary care provider if they're willing to do this. You know, some providers are not going to feel comfortable regardless of their training, right? And that's why we have people like you.
And that's okay. I would rather a provider that's not comfortable not prescribe that medication.
Exactly. That's how I feel 100%. I want you to be able to go somewhere reliable and suitable for your situation.
Right.
So let's talk about MAT. What, medication-assisted treatment. Can you explain its role and some of the controversies about it?
Sure. Yeah. Okay. So the controversies are going to be you're switching one drug for another. That's the big one. That is not the case. You are getting rid of the chaos involved with substance use.
And this is particularly regarding opioids, correct?
I would say that. Particularly regarding opioids, that's the one with the biggest stigma because you're going to be on a partial opioid agonist. So you're still going to have the effects from opioids, but you just don't have the euphoria that you would experience with full agonist opioids. So yeah, that's where the stigma comes in, and that's where the controversy is like, especially in AA and NA. Funny enough, they really do not like when you're on substance or when you're on MAT.
Right.
So, it's definitely a big topic of conversation. What you're doing when you're on MAT is you're getting rid of the chaotic aspect of trying to find your next dose, trying to find whatever you're doing to try to get that next feeling. You're getting rid of that. You are in a controlled environment. You're stable. Your mind is able to kind of reconnect. You're able to take from therapy what you can take. You're also able to, just have a normal life, So it's like risk versus benefit. Right. God forbid a patient were to relapse, they overdose on fentanyl, they die. Or they're on MAT and they're fine. They're okay. They're going to work. They're living normal lives.
I think that would be the goal, right? To be able to live a healthy, happy, normal life, right?
Exactly.
And so I knew this was controversial when we were working together, and I just saw, there's people out there who had knee surgery and got addicted to Vicodin, right? And they had no intention on doing that, and we were able to help get them off that and onto the lowest dose of Suboxone for they just did one, even half of a 2 milligram, right?
Exactly.
And so 1 milligram a day just to help get the stability and life, and they were working full time, very successful,
Exactly.
saving money, had a family, and that was to me a success.
Absolutely.
Yeah.
I totally agree with that. And the great thing too, so let me answer this. It's difficult to come off of Suboxone. It is. Just like it would to any full opioid
agonist. Like
right.
And there are some patients, I believe. I remember, I would offer Suboxone, hey, let me help you get off heroin, right? Or whatever it is you're doing.
Right.
And they did not want Suboxone because they said they'll withdraw more from Suboxone than they would from that. And and to me, I hate to hear that.
Right.
But then I say, then you need to go into an inpatient setting where you can be monitored and comfortable.
Right.
Right. So it's just a matter of making the means meet and finding what's best for you.
Exactly. The willingness for treatment, all of that. But thankfully, what's new on the market, I mean, it has been such a game changer getting patients off of buprenorphine product has been long-acting buprenorphine. So that's the monthly and the weekly injections.
Yes. Sublocade,
and now there's a new one called Brixadi.
Yes.
Game changers. It has been incredible. I have patients that will do a couple injections, sometimes even one, and they're like, I have zero withdrawal symptom.
That's
zero.
phenomenal.
I've been off of it for 6 months. I've got a year sober. Like, it's been such a great thing.
Is it because it's because of the long-acting injection, it's able to just slowly dissipate from their system?
Right. They metabolize it very slowly. You can say you get 4 injections as an example, and you were able to taper from 300 milligrams monthly to 100 milligrams, and then you're off of it. You still may test positive in your urine for buprenorphine up to 6 months after that last injection.
Wow.
Although you're not having any effect from it.
Right. It's not like you're high on it.
No, not at all. Not at all.
Wow.
You're not having any effect from it still, but your body's still metabolizing it at those microscopic doses.
Wow.
So there's no withdrawal, and it's been a game changer.
That is great.
Yeah.
And insurance can cover that too.
Thankfully.
Okay.
Yes. Yeah.
Wonderful. And then can you explain the difference between Suboxone and Subutex?
Sure. Yeah. So
and then let's get into naloxone.
You got it.
Okay.
All right. So Suboxone is going to be buprenorphine and naloxone combined. Subutex is just buprenorphine. Buprenorphine is the active partial opioid agonist. So that's what's working. The naloxone has no oral bioavailability. So if you were to take it orally, it does nothing. Naloxone is the same thing as Narcan. Most people have probably heard of Narcan. Mm-hmm. The only reason that it's kind of differentiated and that there's 2 options is they're trying to avoid patients from misusing their Suboxone.
Or Subutex.
Yeah.
Right? Yeah.
So if the Subutex has a higher ability for misuse, the Suboxone itself with the naloxone, you can't snort it, you can't shoot it, you can't do any of those things because it has the naloxone, which is Narcan.
Right.
Those are
where
the only
it's not bioavailable when done orally.
Exactly.
But it will be effective if they were to try to use it inappropriately.
Correct.
As you said, by crushing and snorting or trying to melt it down and inject it.
So it's just a barrier.
Exactly.
A lot of patients think, oh my gosh, I don't have the naloxone. There's no barrier. There's no opioid blockade. No, what's blocking your opioid receptors is the buprenorphine.
Exactly.
That's a very common misconception. So that's the big difference between the 2.
And then let's talk about Narcan, naloxone, and then we can go into naltrexone.
Sure.
Okay.
Yeah, so Narcan is going to be the life-saving. Someone's overdose. They have intranasal sprays. They have injectables that you can get. I think it's super beneficial if somebody just has that on hand. Mm-hmm. Have at least 1 dose in your car, in your purse, wherever. Just if you can save a life, save a life.
Well,
I always have one on me.
Exactly. And nowadays, obviously cops and firefighters have them on at all times, but nowadays I see patients who are on chronic opioid medications from pain management are prescribed naloxone to have on hand at home.
Exactly.
Yeah.
God forbid, just in case. Yeah, they forgot they take the dose or whatever, and they
if they were to overdose, exactly, accidentally whatnot.
Yeah, so that can just at least help get treatment sooner rather than later, just something. So that's naloxone. And then naltrexone is a very commonly prescribed medication, again, medication-assisted treatment that's utilized for both alcohol and opioid use disorder. Great medication, 1 pill once a day, generally pretty well tolerated, not a ton of side effects. If you were to take naltrexone and then you were to take any sort of opioid, including Suboxone, you would have no effect from it. The naltrexone is blocking those opioid receptors from absorbing anything that comes in there. Naltrexone helps with cravings for alcohol. Really great medication. If you were to relapse, God forbid, you take your first sip of alcohol, you don't get that head euphoria where like, man, this feels good, I want to keep drinking. Gets rid of that completely. Does not make you physically ill like some older medications like Antabuse would. So again, a little bit more well tolerated. And funny enough, we actually utilize it for weight loss medication.
Yep.
Yeah.
It's in contrast,
Right.
exactly. Where it's mixed with Wellbutrin, an
Exactly.
antidepressant.
Yeah.
Yes. And it's that medication, by the way, is phenomenal for people who have that stress eating disorder. Like if they just constantly want to eat
Food
when they're
addiction.
stressed. Yes.
If you think about it, you know, there's definitely.
I'm telling you, there's addiction everywhere.
It's everywhere. Absolutely.
And so, yes, naltrexone does come in an injectable form as well, like you said, like a long acting.
Exactly. So that would be Vivitrol. That's a once monthly injection. Same thing molecularly than you would be taking the pill, but it's just one less pill to take. So it's convenient.
And the good thing about the naltrexone route versus the Suboxone route for opiate addiction is there's not withdrawals.
No, you don't build a tolerance. You don't build a dependence. You can stop taking it without any issue. You're not going to experience any withdrawal.
And there is safe data for being on this long term.
Right. Yep. It's actually recommended at least 1 year. Mm-hmm. Get a year of sobriety under your belt and then kind of revisit.
Absolutely.
Yeah. Great.
And so, another thing. So there's AA, there's NA, there's CA. Is there other ones that I don't know about?
Celebrate Recovery is one.
Okay.
Smart Recovery.
Smart Recovery is one, right? And then do you ever use the app? Is the app still out, the Restore? Or is it
Reset or something like that? Yeah. I have not talked to her in a long time. I don't know if it's still out there. That's a good question.
I think it is because I actually just looked it up on the App Store recently, but I don't know if it's still functioning. That's the only thing. But that's also for people who just want to do it in the privacy of their own home kind of thing.
Yeah, there's some technology coming out that's really useful.
And you can attend meetings online now or Zoom. You don't even have to go anywhere.
COVID really helped facilitate that. I'm sure there was options before, but now you can just go online and find any meeting at any time, essentially.
And so can you just kind of now we're on the recovery side of things. What does recovery mean?
That's a great question. So recovery is different for everybody. There's harm reduction, which is, just cutting back and making sure that you're doing all the right things and you're responsible with whatever you're doing. There is complete abstinence, which is sobriety. That's where you are not using any substances. You've completely removed that from your life. So a couple different things to kind of define recovery, and it looks different for everybody.
Thank you for clearing that up, because there's also, when I watch my, I'm embarrassed to say this, but some of my reality TV shows, and they're based out of California, they have California sober, right? That's what they typically say, and that means that's they're sober, but they can have marijuana, right? So I always...
everybody defines it individually. There's no clear cut, this is what my recovery is. It's all dependent on the person.
And, even with medical marijuana, certification, I always like to stress, look, as long as you're not doing this as a coping mechanism and you're doing this for yourself to help you go to bed or to help get rid of the night terrors or, or to help with appetite if they have cancer, right? Or, we are doing it in a medicinal way, then I'm okay with it.
Yeah, right? 100%. There's definitely a time and a place.
So what about relapse? Is that inevitable?
Not necessarily. Okay. You'll have a couple of patients that will be one and done. They went to treatment once and they were able to just kind of overcome it, and that's it. Relapse should not be looked at as some moral failure, like we mentioned earlier. It's like you go into remission first. Not remission, excuse me. It's more of a flare-up, like any medical condition. Yeah. You know what I mean? Maybe something slipped where you can no longer handle the stresses of life. And you're reaching for something to help you feel better. You're reaching for that coping mechanism that you have utilized in the past. You need to just get back on board. You need to address yourself. You need to make sure that you are identifying what you're doing. You are being truthful with what you're doing, and then kind of move past that and move forward.
And hopefully, as the person is through their recovery, they're attending meetings or at least working with a sponsor, which we could talk about that a little bit. They might have worked the STEPS program, which I give a lot of people props for that, because the STEPS is hard.
Not easy, but recovery should not be an easy thing for you. It's got to make you uncomfortable. You got to make sure that you're growing through that discomfort. But yeah, so there's 12-step programs. A lot of that's utilized in AA and NA. Getting a sponsor, you typically will meet them through one of those meetings. And that's somebody who's gone through the steps themselves, and now they're taking on sponsees. So they're going to help you walk through the steps, just like they did. So it's a great tool. It's definitely something that has been tried and true, and it works for a lot of people. And it's a great resource. Does it work for everybody? No, it doesn't. Right. And it's not a cookie cutter sort of approach. You can't Just say, you got to do this and this is what's going to work. That's not the case for everybody.
And there's people who repeat the steps.
Right.
And I'm pretty sure if you have a different sponsor, you're going to have a completely different experience with going through the steps with this sponsor versus another sponsor.
Exactly. That's so true.
I would love for you to maybe let us know or educate us, because back in the day, there were other drugs out there that people have never heard of. And I'm sure there's new ones out there that I've never heard of even. Like there used to be spice, right? So people would smoke spice instead of marijuana because like apparently I was told like that wouldn't show up on a drug test, but it was technically like a chemical and people were having psychosis from that.
100%. Yeah.
There was crocodile where people were like really hot temperatures and their skin would look dry up like crocodile.
Right.
It's a chemical. Once again, like these are things that are like, to me, they're terrifying. I would never even think about just trying it out if I even knew. And so is there anything, what's the newest other than the kratom we talked about in the 708?
Yeah. So
what else is out there?
Flocka is still out there.
Okay.
Shockingly.
And Flocka that was back when we were working together.
Right, exactly.
And that's the high temperature one, right? Where you're extremely hot, so people will be stripping.
It's like a stimulant, essentially. So very similar to like a cocaine or crack cocaine sort of effect. But yeah, and maybe Molly even mixed in there too. But so we have that. Another gas station one is called tianeptine or Zaza. That one's scary too. It's an opioid-like effect, similar to the kratom. It comes in capsule forms. It comes in at gas stations. You can't test for it, but you still will get that effect. There's also, what are some big ones?
What about kava?
Kava, we don't usually see, interestingly enough.
All right. It's a tea, and I know a lot of times like there's tons of kava shops, so I didn't know if that was something that is frowned upon or not.
It's frowned upon in the treatment setting, absolutely. Okay. If you're in recovery and if you're in treatment, it's not something that we are encouraging anybody to do. Mm-hmm. And if we find out that you're utilizing it, obviously there's steps that we'll take. We'll either bring you up to a higher level of care, just kind of stabilize things.
Sure.
And get to the root cause. Why are you doing this? What's going on? What are you looking for?
Exactly.
Let me think if there's any other new ones out there. The Zaza was the big one, the kratom, the 7-OH. But yeah, you see alcohol, you see opioids, fentanyl, carfentanil, the not hydralazine, it's the, what was it? The one in Philadelphia that kind of came down here. Are you familiar with that at all?
Ooh.
Where it was causing really bad sores.
Yes, I cannot think of the name of that either.
Trank there was like the street name.
Yep. It was a combination.
Right.
Yeah.
Exactly. It was like a horse tranquilizer.
Yeah. Which, I mean, that's where, I want to educate people out there listening that never pick up something off the ground that you don't know what it is.
Right.
I mean, there have been police officers who died from touching substance without gloves.
Right.
And just a speck of fentanyl absorbed through their skin.
We've heard it from people that smoked weed, and they're like, I had no idea, and they overdosed.
Right.
Thankfully, they lived to tell the tale, but it can be a totally different outcome if you're not careful.
Right. And so I just want people to be aware, like, just because it's at the gas station doesn't mean it's okay.
Right.
I mean, they had that back in the day with ephedrine, like the weight loss pills. I mean, if you should not be taking weight loss pills from a gas station.
No.
Okay.
You should
not.
So
let's reel it in and seek professional help or advice, right? Go see your doctor, your primary care, your psychiatrist, whoever it is.
Exactly.
Awesome. Kathleen, this has been so good and knowledgeable and putting awareness out there about addiction medicine. Thank you so much for coming on. How can our audience find you?
Oh, great. Thank you, Deanna. I appreciate it. This has been awesome, too. I really appreciate you inviting me on the podcast. This has been a really cool experience. So you can find me at South Coast Psychiatric Services. That's my office. We do telemedicine care. That's just a basic outpatient. I'll see substance use. I'll see general psychiatric. I'll see whatever. You can reach me there. We have a website. It's southcoastpsychotherapy.com. And then I have a business where I provide medical services to treatment centers, and that is recoverymedicinepartners.com. So either one of those, depending on what you're looking for. But I really appreciate you having me on the podcast.
And I'll put all that in the show notes because we want everyone to be able to reach you.
Thank you so much.
Thank you.
All righty.